Hello, everyone. I wanted to take this opportunity to welcome you all to our webinar today on producing immunization expenditure data for policy and planning. Thank you all for joining us, and good morning and good afternoon and good evening to everyone wherever you may be. This webinar is hosted by the Immunization Resource Tracking Project at Abt Associates and the Learning Network for Countries in Transition, or LINKed. My name is Grace Chi. I'm a Senior Program Director at Results for Development, or R4D. R4D is the Secretariat for LINKed, and which was set up about 2 years ago to support countries transitioning away from Gavi support. And the way it does that is by facilitating linkages between Gavi transitioning countries and partners so that countries can access resources, expertise, and share experiences with each other in order to successfully address transition challenges. The Immunization Resource Tracking Project at Abt Associates aims to strengthen country-level data on immunization financing and immunization sustainability. So with that, I want to pass it over to Shipra, who will be providing an overview before she begins the discussion with panelists. Shipra.
Thank you, Grace. So the question we're going to try and answer in today's webinar is how can countries produce and use immunization expenditure data to inform policy and planning with the ultimate goal of sustaining and improving their immunization services? These are challenges that are faced by many countries, and in particular by linked countries who receive Gavi support and have to plan to transition away from that support. So the first thing we wanted to do was start by giving you a brief introduction to two global frameworks that are used to track immunization spending. The first framework is the Joint Reporting Form developed by UNICEF and the World Health Organization. This reporting form has a suite of immunization indicators, a subset of which are specific to financing. On this slide, you can see the list of those indicators which are related to government spending and total spending on routine immunization services and spending on the vaccines used in those routine immunization services. So the WHO, UNICEF, Gavi, and partners have actually developed guidance on how to report using the JRF. A recent evaluation of the JRF revealed some challenges in the reporting. They found inconsistency in reported values from year to year for the same country. Also, missing values were an issue. And another limitation of the JRF is that it doesn't include shared costs or unearmarked costs. So we have been working with the World Health Organization to explore solutions to these challenges, one of which is linking this JRF to the System of Health Accounts framework, which is the next framework that I'm going to tell you about. So the System of Health Accounts is a framework that tracks total health system spending. This framework can be used to estimate national health expenditure and to measure the flow of resources from the sources of funds, such as donors and government, to where they are being spent, who is managing them, and what they are being spent on, be it commodities such as vaccines or salaries and such. So the results from a health accounts exercise can actually be used for reporting on the JRF indicators. It turns out that the latest version of this framework, the Health Accounts Framework, which is called SHA 2011, since that's when it was developed, actually tracks spending by disease area. And one of those disease areas is vaccine-preventable diseases. So this allows the framework to track immunization expenditure with improved accuracy and detail compared to the JRF. Another advantage of the SHA framework is that it includes shared or unearmarked costs in the estimates. And if this framework is customized slightly, it can also distinguish spending on routine immunization versus spending on campaigns and supplemental immunization activities. So that's basically an introduction to the two frameworks, and now what we're going to do is move on to interviewing our expert panelists who we have on the line. to get some country perspectives on the production and use of immunization expenditure data. We're going to start with our panelists from Georgia, a linked country that receives Gavi funding. Our speaker today is Ketivan Goginashvili. She is the head of the Health Policy Division of the Ministry of IDPs, Labor, Health, and Social Affairs in the Republic of Georgia. Keti is also a professor at the University of Georgia. She holds an MPH and doctorate in health economics. Keti has participated in preparing and using health accounts data, the National Health Report, and other tools for health system performance evaluation. Keti, thank you for joining us today and welcome. Could you please start by telling us how is data on immunization spending useful in managing the immunization program in Georgia and in planning for transition from Gavi funding?
Good afternoon, good morning, or good evening, everyone. Thank you for possibility to participate in webinar and share our experience to other countries. Immunization state program in Georgia was implemented from 1995. Immunization coverage is about 95%. Government expenditure on immunization is rising every year and is 3% of public health expenditure. From 2005, countries producing SHA, an instrument that enable us to generate immunization spending data. SHA result is based to develop monitoring and evaluation of state immunization policy and immunization state program. Immunization spending data gives answer to the question, what is the share of state and household contribution in immunization expenditure, and gives possibility plan of policy for reduced financial burden of population. One of these examples is this reduction of out-of-pocket payment on immunization with the implementation of hexavalent vaccine, WHO pre-qualified vaccine with high credibility. Decrease of OP was also confirmed by the Abt Associates survey in 2018. We are using SHA results for advocacy of sustainable and growing financial trends of immunization during planning of MTF. As a result, the amount of state funding on immunization increases annually. In 2012, it was 4 million Georgian lari, and in 2017, it's to 24 million Georgian lari. Georgia has a transition period when funding of donor organizations such as Gavi Global Fund is gradually reducing, and government is taking responsibility for the financing of the immunization services. Share of Gavi and other international donors, as you are seeing on the diagram, is 3-4% of total immunization expenditure. In transition period, the information about sources and amount of immunization expenditure is very important. Health account results help us correctly adjust the transition period to the need of population, health priorities as a country capability. There are diagrams of immunization spending by financial sources. Main actors is government, then OP and international aid.
So could you also tell us a little bit about the challenges that Georgia has faced in terms of producing and using immunization expenditure data?
Yes, of course, challenges in producing immunization expenditure data. During 2-3 years, Georgia OP on immunization is decreasing, but still is high, as you see 7-9% of total immunization spending. Estimation of out-of-pocket expenditure on immunization is a great challenge for us because, as you know, Georgia is a country where 91% of health facilities that are provided immunization services are private. They were not interested to register cases of commercial vaccines in the immunization registry, which is the only routine source to estimate OP. Since 2017, the Ministry has implemented result-based financing mechanism for immunization, which significantly increased the quality of data. It should be mentioned that HBS survey, Household Budget Survey of Geostat, does not contain questions about immunization costs. From 2019, we are going to implement electronic health record in primary health care level. EHR will be additional source of information, and it is also important to know that utilization and expenditure survey, health utilization and expenditure survey, which is provided every year by the financial technical support, WHO, World Bank, and Global Fund, is another source of information of estimation OP on immunization. We also had a problem of disaggregation of service cost versus vaccine and supply, but implementation of SHAR 11 and the modify of case registration system help us to solve this problem also. We are trying to solve all these problems and get more accurate data. Maybe other countries experience how we will address the challenges more available for me as our experience for other countries.
Thanks, Keti. It sounds like your experiences and challenges will hopefully be something that our linked countries in the audience can relate to. We're now going to move on to our panelist from Benin, a country that has produced and used immunization expenditure data from a recent health accounts exercise. Just a reminder to the audience, if you have questions for Keti, you can enter them into the Q&A window now or at any point during the webinar. So let's move to our next panelist, Dr. Laundry Kokle, who's currently the logistician for the National Expanded Program of Immunization in Benin. Laundry works at the National Agency for Immunization and Primary Healthcare of the Ministry of Health. He obtained his master's in economics and management from the Paris Dauphine University in 2011. From 2013 to 15, he worked in the Democratic Republic of Congo for the World Health Organization as an immunization field consultant. Prior to this international experience, Laundry was a health district manager for 6 years and was responsible for immunization activities at the district level. Laundry has also participated in many international conferences, workshops, and trainings related to vaccinology, logistics, and disease surveillance. Thanks for joining us today, Laundry, and welcome. Could you please start by telling us what types of questions did the immunization spending data from your health accounts help answer in Benin?
Thank you. Good evening, everyone. Thank you very much for your question. Benin has a small experience in the practice of health accounts. And the expanded program on immunization API, where I'm currently working, really benefits from this exercise as it's finding answers to some of our concerns. First question this exercise can help to answer is, what is the cost of the program in terms of expenses incurred, including shared costs? As you know, it is very interesting for future planning reasons to know the overall expenditures that are incurred to ensure student immunization. The second question is, what is the cost of the program in terms of, in comparison, with other health interventions like HIV, AIDS, and malaria? As you know, we are in an environment of competition between programs in terms of resource mobilization. And you know, results are becoming increasingly rare. So comparison with other programs helps demonstrate the competitiveness of immunization programs in terms of efficiency. Third question is, what is the cost of different immunization strategies, namely routine immunization and mass campaigns? It is very useful to compare these two strategies and to analyze the reason of difference in cost and to know if this is trend impact on the effectiveness of the two strategies. Fourth question, what is the immunization expenditure for, what is the immunization expenditure per live birth? You know, it's a good economic indicator to evaluate the efficiency of our program and to compare ourselves with other countries. For example, from the analysis of the 2015 health account, it came out that for a DTP3 coverage of around 83%, according to the GRF, the immunization expenditure is around $28 per live birth. In Burkina Faso, a border country, this country spent almost the same amount for a better DTP3 coverage, about 88%. There are another country, bordering country called Niger. We spent $40 per live birth for a lower DTP3 coverage of 68%. Last and not the least question is, where is the funding for immunization coming from? And this helps to assess, on one hand, the household contribution, and on the other hand, the government contribution to immunization expenditure. And this is useful for equity issues and to ensure the program financing sustainability. So globally, here are some questions we can get answered from the exercise of immunization expenditure analysis coming from health account. Thank you very much.
Thank you, Landry. So Benin conducted a health accounts exercise with 2014 and 2015 data using immunization guidance for SHA that our next panelist is going to tell us about. We know that you also produced a policy brief using the data from the health accounts. Could you go into a little bit of detail about how the data and the policy analysis in Benin was received by stakeholders and how they are actually being used in Benin?
Thank you very much. I think the policy brief recently developed on the immunization financing situation extract from the health account was well received by the API program managers. And as I said previously, it helped us to found in it answers to many of our concerns. Second use of this data is that this brief helps us to in the advocacy for increasing immunization financing. For example, recently we used health account data as evidence in our last roundtable on immunization financing in October 2018. Also, this data allows us to convince our stakeholders, immunization stakeholders, to understand past spending and to forecast future spending. Third use of this data is for government officials, mostly the Ministry of Financing, to understand the best capital spending compared to neighboring countries. As I told previously, this is useful for improving our immunization strategies and to make them more efficient. Data from health account analysis can also be useful at sub-national level with immunization expenditure. For example, these three levels understand the cost associated with immunization program. Then they are more aware that vaccination, of course, is a free of charge intervention for population. However, results are made available for it, and then that motivates them to reduce wastage and to increase immunization coverage. The future use is that we plan for our next API Interagency Coordinating Committee, ICC. We plan to show this data to the ICC meeting, which will be held in January 2019. So globally, here are some use we are doing with this data coming from health account. Thank you very much.
Thank you, Landry. It's great to hear that the results and analysis have been so useful in Benin. Just a reminder to our audience, if you have questions for Landry, please submit them in the Q&A window now or anytime as the webinar continues. We're now going to turn to our global expert on health accounts who's going to share with us 2 useful resources for producing and using immunization expenditure data. Our next panelist is Tesfaye Ashagari. He has over 16 years of experience in the health sector with expertise in health financing. Tesfaye has supported development of policy and legal frameworks for implementing health finance reform, organized and coordinated policy dialogues and consultations, helped build capacity for healthcare financing reform, and led resource tracking exercises, costing, and analysis. Tesfaye, thanks for joining us today and welcome. Could you please start by explaining to us how data on immunization expenditure can be produced?
Thank you, Shipra. I think being the last panelist in this webinar helps with taking advantage of the heavy lifting of our previous panelists as well as the initial presentation. So thank you for making my life easier. So when you talk about taking a step back on the points that has been raised earlier, the SHA in general captures immunization spending through two classifications as it stands now, the SHA 2011 framework. The first is through the functional classification, whereby we have a classification called immunization programs under the prevention category. And the second is at the disease level, there is a classification that is vaccine preventable disease. These 2 classifications help link the immunization spending to other classifications within the SHA 2011 framework, which is those classifications related to how the health sector has been financed. So in this case, it will help us link the immunization spending to how they have been financed, who their sources have been, and at what level those spending have been spent. Is it at hospital level, at the primary level, or elsewhere? The other component is this classification also allows you to tag the inputs that have been used to provide the services. And through this, it will help you track expenditures, the immunization spending broken down by the inputs that have been used, such as the labor, the vaccines, and other inputs that have been used to provide the service. I think I would like to touch on your earlier point related to the 2 frameworks as well. So that is basically the first is for the JRF. JRF has been there and has been tracking the financing component for immunization and across many spectrum of countries. And this SHA 2011, the aim is to be able to help complement the effort that has been there through the JRF to be able to provide a source of information for the JRF for countries to report their immunization financing indicators on. And this would hopefully allow countries to have consistent way that they are measuring the immunization spending and be able to compare them across. But getting back to the SHA, also similar to other programs, when it comes to immunization, there are 2 types of expenditures that the health accounts analysts or the immunization program managers face, which is basically there are expenditures that have been earmarked, such as vaccines, but also there are other expenditures that are shared across different services and programs, such as salary of the health worker that's working in the facility. So now there's not so much of a problem in terms of teasing out those that are earmarked because they are straightforward tagged with the service related to immunization. But for those shared expenditures, which is the majority that are within the public sector, for example, then we need to be able to have some kind of distribution key that can help unpack those expenditure and tag them to the immunization services or other programs. So The SHA 2011 and the guidance that you have mentioned earlier provides some insight for users or producers of the exercise, the health accounts, with some tips on how to unpack that expenditure and to the different programs, including immunization. So I think that's I don't know if we want to go into the nitty-gritties of how do we do it technically. Probably this webinar won't be enough. It would require a session on its own. So I would refrain from getting into that. But I'm happy to answer if there are any questions in particular. But one thing that we need to note for all the health accounts experts and the immunization program managers that are working in the country setting, in order to be able to effectively get information on the immunization spending to the maximum, there needs to be a customization that needs to happen mainly at the functional level. That is to unpack these immunization programs classification into those that are routine versus supplemental. That would help the immunization program inform its programming decisions as well. Here, I would like to put a plug in for that guidance again, because it provides those insights and more. It talks about what classifications are relevant within the SHA 2011 framework for immunization. It also provides what the common sources of spending for immunization are in a country setting using country examples. And it also provides issues to consider to tease out when teasing out the shared expenditures, which Katie mentioned was one of the challenges that they have been facing.
Thanks, Tesfaye. Hopefully your tips will be useful as countries use the immunization guidance in their health accounts exercises. So once the data is produced, could you tell us a little bit about how the data can be interpreted and analyzed to inform immunization policy and programming, especially for linked countries?
Thank you. So the data that has been produced through the SHA for immunization helps answer these common questions related to sustainability, which Katie and Landry both raised earlier on in their country experience, trying to look at how much of the resources are domestic versus external. That's one component that can be answered. The other component is related to efficiency, which Landry raised earlier, trying to look at expenditures and benchmarking one country's experience against the others in terms of what is the value that they're getting out of the spending in terms of coverage, boosting coverage. That would help with in looking through whether there are efficiency questions that need to be efficiency issues that need to be addressed. The other component is equity, the role of households in financing the immunization, and mainly at that, the role of out-of-pocket payments, which Katie mentioned has also a role to play in terms of understanding the equity implications of the financing for immunization. Another component I think that is within the public financial management realm is trying to see how effective has been the spending vis-a-vis the plan. And for immunization, for example, country teams regularly produce country multi-year plan for immunization, comprehensive multi-year plan, and for the spending information can help see how far the spending is vis-a-vis the plan that they have in the CMYPs and try to help country program managers, immunization program managers, as well as other stakeholders take corrective action when there are deviations. So maybe just getting back to the point that Landry raised earlier and on the efficiency, on the slide you will see how an example of how the immunization data can help answer the efficiency question. You will see through combining information on spending versus the coverage of some indicator, the coverage indicator, you can be able to just see how much, where the country is, where a particular country is in terms of effectively utilizing the immunization financing to boost coverage. So this would help you, for example, if you look at the countries that are on the top side, top right, you will see Sierra Leone that has been spending around $70 per capita, 71, 72, compared to Liberia, which has been spending similar amount, but their coverage is around 76, 77%, while Sierra Leone's is around 91, 92%. So there are things that would be able to help. Of course, this is the first question that needs to be answered. There are deep dives that need to be happening, but the health accounts results would help you first go through whether there are issues of efficiency that need to be addressed. The other component is the sustainability, and you can be able to just look at, just by looking at the percentage of government contribution across the different countries, you can be able to just see where the country is in terms of financing their immunization funding domestically and how sustainable the system is. Yep. So here also I would like to just put a plug in for a work in progress, a material that is going to be coming out soon. It's a primer that is intended to be able to help the immunization program managers in different countries to understand what type of information, what is the value of having the immunization spending information, what are the methodologies that are existing, and what are the program issues that can be addressed through them, and how to package those information to be able to inform programming decisions. And this would be out within the next week, and we will send the link to the material as well to all participants.
Thank you, Tesfaye, for sharing some details about the production and use of immunization spending data. I think the two tools that you said are in development and almost ready will be hopefully very useful for our audience. And we'll talk about those a little bit later also. So just a reminder to our audience to submit your questions in the Q&A window. You can indicate if your question is for a particular panelist, or it can be for all panelists also. So now it's time for our Q&A session. So we're going to see what kinds of questions you all have around producing and using immunization expenditure data in your countries. So we're going to start with a question for our panelist from Benin. Laundry, the question for you is, would the health accounts data in Benin still have been useful even if you did the exercise for just 1 year of financial data and not 2 years?
Okay, thank you very much. Obviously for me, whatever is the time origin, 1, 2 or more years, the analysis remains useful for the country. It gives a descriptive situation that allows the country to draw conclusions and to take action. It is true that the extension of the period of analysis gives more visibility in the trends and is desirable, but failing to this, the analysis of 1 year remains contributive. So for me, both 1 year or more or 2 or more years is useful. You can have the answer with 1 year, but you can follow the trends with more years. So I suggest to do it at least one time and to do it as much as possible. Thank you.
Thank you, Laundry. So we have a question for our panelist from Georgia. Ketty, your data slide showed that the government's contribution to immunization spending has increased over time. In your opinion, what has led to this increase in public expenditure on immunization?
Thank you for the question. Public expenditure on immunization is increasing from 2012, and the increase is very significant from 2016 when we are implemented hexavalent vaccine, which is WHO qualification, and people's believe vaccine quality of the vaccine is increasing, and they're not buying commercial vaccine. Also, we have transition period, as I mentioned, and the government take responsibility to spend more on immunization when the donors are finalizing their work on the countries and that's why from 2019 it's increased public expenditure on immunization. Also, vaccines qualification is increasing, and that's why so huge increasing is on our data.
Thank you, Keti, for that answer. So we have a question for Tesfaye now. Tesfaye, how long does it take to do a health accounts exercise and get the results?
Okay, thank you very much. Well, it's kind of on average, the health accounts exercises have been lately taking around 6 months to produce. Of course, this depends on how much primary data a country needs to capture information, but one thing that I have realized is that, for example, for countries that have been doing it on a regular basis, the time it takes for them to produce the health account goes down, and for that, so it can take anywhere, if it's a new country, it might take up to a year, but for most of the countries that are doing it on a regular basis, within 1 to 3 years interval, it takes them around 6 months.
Okay, great. That's helpful for, I think, countries in our audience. So our next question is for Laundry in Benin. Laundry, how often do you plan to conduct spending analysis using the health accounts in Benin?
Thank you, Shifa. The health account analysis on immunization will be done each time we conduct the health account in the country, and we currently conduct the health account analysis every 2 years. So it's planned to do it every 2 years. We will have to look for the data, the situation of immunization financing extracted from health accounts.
Thank you, Laundry. So our next question is for Keti and Laundry. Maybe Keti, if you could answer first. How is planning and budgeting done for immunization? Does the EPI or the immunization program do its own budgeting, or is it done by the Ministry of Health?
Budget. Budgeting process is a responsibility of the Ministry of Health, and we are using all data, epidemiological data, all the quality of immunization and main drivers, and also previous years spending on immunization, and that's why we are doing our MTF.
Thank you, Keti. Laundry, could you answer the same question? How is planning and budgeting done for immunization? Does the EPI do its own budgeting, or is it done by the MOH?
No, the first draft is done by the API in our country. So the API staff first do the first draft coming from the CMYP target, and then after this draft is shown to the direction of planning of the Ministry of Health, and then the direction makes his observation, and finally we post the final draft of this planning and budgeting for immunization. So it is first conducted by the API, and then it it is endorsed by the Ministry of Health.
Okay. Thank you, Landry, for clarifying that for our audience. I have another question for you, Landry. To what level, if any, were the district-level staff in Benin involved in the health accounts process? And have there been any events to communicate the results and policy implications to district-level staff?
Thank you. I already answered directly to this question. This level is mostly involved for data collection, not for something else. It's done mostly when we want to collect the data. We involve the district, taking the expense support they have. So the event to communicate with district about the health accounts mostly are the training sessions. The API mostly organize 2 sessions of training to target it to district level. And during this session, we have time to discuss about the health account and to discuss about the cost of immunization. Second event, API review. You have some review we conduct once a year. And for this review, the district staff are invited, and during this review, we show them the trends in terms of financing related to immunization. So these are some events we share with them, the data from health accounts. Thank you.
Thank you, Landry. Okay, we have another question. We have lots of questions, so let's see how many we can get through. We have a question for Tesfaye next. So the question is, go up. How does the SHA methodology or JRF distinguish between immunization service delivery costs and other service delivery costs? Or do immunization costs refer just to vaccine?
Thank you very much. So I think the immunization expenditure is inclusive. It includes the vaccine and also the vaccine delivery costs, information on that. How the SHA tracks and tries to distinguish those expenditures is by tagging the immunization spending and mapping it further into the inputs that have been used to be able to provide the service. So by inputs, I'm talking about how much of it was going to labor, how much of it was going to the vaccines, or how much of it is going to other running costs. Mm-hmm. So through doing that, it will provide information in terms of that are disaggregated by the vaccines as well as the delivery costs.
Okay, thank you. So the next question is for Tesfaye also. Tesfaye, what is the main data source for a health accounts exercise? Is it like a Ministry of Health Expenditure report, or what kind of data is used in the SHA?
Thank you. So I think the health accounts in general includes capturing information from all sources of financing for health. So it captures information, as you rightly put, in terms of spending from the government. Usually it is captured from either the Ministry of Finance and a combination of information that is obtained from the Ministry of Health. Also, however, it also captures information of financing through the development partners as well as NGOs that have been managing it, and employers and insurance whenever there are benefits that are being provided for employees and staff, and also household spending as well. So it captures information from all sources of financing.
And what are the main sources for household spending?
The main source for household spending comes from the household surveys. Okay. So usually in the household surveys, they have some questions that have been included in terms of understanding what is the purpose of visit to the facilities and whether they have paid for them. So that's how we get that information.
Okay, great. Thank you, Tesfaye. So we have another question for Ketty. Ketty, the question for you is, what are the cost drivers of immunization expenditures? Is it increasing coverage, or the price of vaccines that drive the cost?
Right. For us, main driver is coverage of vaccine. We want 2020 reach elimination of measles. That's why we are doing a lot of things, and main driver coverage of vaccine and the quality of vaccination.
Thank you, Ketty. Okay, so let's see. I think we have another question for Tesfaye. When thinking about efficiency, Tesfaye, could you comment on what the experience has been in introducing PFM reforms in planning, budgeting, and budget execution? I'm not sure if that's within.
Okay. All right. So I think this might be taking us into the PFM and health financing reform area. Of course, one of the key things that has been part of the PFM reform is looking at strategic purchasing and making sure that investments in health are going towards services that are high impact and efficient. So the PFM reform is more or less related to institutionalizing mechanisms in terms of how the budgeting process can be able to align with providing this strategic purchasing for the ministry or the body that's financing it. I know it might go further into, and this might be a wider question that we may need to answer further on as well. Definitely, once we have information related to the budget as well as the spending, the execution rates and how effective the entities are in utilizing the resources is also a factor that would come in to that PFM reform as well.
Thank you, Tesfaye. I think we have maybe one more question, and I think this might be for Landry and Ketty. If they could talk about additional challenges that exist in timely and routinely collecting and reporting on immunization expenditure data. It sounds like this audience member is looking for a little more detail in what kind of challenges you face in getting data on immunization expenditure. So maybe if we could start with Landry, and then we'll go to Ketty, and then see if Tesfaye has anything to add.
Okay, thank you. For me, the biggest challenge is to get information from indirect costs incurred by the household to support immunization activities. You know, it's not easy to exactly have the amount that are incurred by families to get to a healthcare center and to get vaccines. So one of the challenges in data collection is to know exactly the perimeter of the indirect costs. Another challenge for me would be the archives. You know, for financing, you need to have some documents which are well archived, archived in healthcare centers, in our administration, and we still have some problem to back up some documents. So these are some missing. We can have some missing data, some financial missing data. So here are some two key challenges I can found in the exercise of collecting data to make this health accounts. But this is challenge common to all the system of information in our country, and we are working to see how we can improve it. Thank you.
Thank you, Landry. That was a useful insight. Let's see if Ketty has something to add to that on, Ketty, the challenges that you face in Georgia in collecting timely and routine immunization expenditure information.
As I mentioned, we are trying to address now the application of service cost vaccine and supply in commercial vaccination process. It's not so high, about 1 billion lari, but we must separate vaccine service costs and vaccine costs. And in commercial vaccine immunization, it's more difficult, and we are trying to find other sources as a immunization register and separate such kind of survey, some HPS survey, to put some questions here, or a US survey, which help us to check and get such kind of information and expenditure.
Thank you. Thank you, Keti. I think we're going to see if Tesfaye has anything to add to challenges faced by countries.
So for the countries that I've worked with, and I think Katie and Landry has also raised those issues, two things that come in. One is the issue of how do we effectively develop a good distribution key to unpack the shared expenditures. That's one question that comes up. And at that, even though I think across most of the countries there are good enough utilization information, when it comes to costing, there are challenges in terms of finding a comprehensive costing exercise that helps understand the intensity of resource use for those different services. So I think I would put the challenge of having a good enough, decent costing exercise is something that comes up often in the countries that I've worked in. The second one is what Katie mentioned, really, in terms of effectively estimating what the role of households is in terms of financing immunization. Of course, it comes from the household surveys in general, but sometimes the issue is that not all household surveys might have that question already in terms of looking at for what purpose have you utilized a health service and did you pay for it, is something that is not consistently applied across all countries that are doing household surveys, regular household surveys. If it is health related, in general, it will have, but the general household surveys, which most countries will rely on, doesn't necessarily have a lot of details beyond saying how much has been paid for health.
Okay. All right. That helps clarify. Thanks. Thank you, Tesfaye and Keti and Landry, for answering that. I think we have time for one more question. So this question is for any of the panelists. So maybe we'll start with Landry. Landry, are you aware of any data quality checking that happens for reporting of the financing indicators in the JRF?
Personally, no. If there are some data quality for fulfilling the JRF, for me, no. If there are some issues with data quality, is what I told previously. It's on collecting the primary data. At secondary level, and there are more chances to have issues with data quality. So for me, if we have to worry about data quality, it should be at the primary level where data are firstly collected. We have the right data on the primary supports. So that is what I can say.
That's helpful. Thank you, Landry. Keti, do you have anything to add on that? Are you aware of any data quality checking for the financing indicators in the JRF? Oh, she's muted. Keti, are you still with us? I think maybe we can go to Tesfaye. Do you have any comments to add on this, Tesfaye?
Yeah, just quickly. I would definitely think if we have someone from the WHO team or UNICEF that is engaged in the JRF might explain it better than me. But I know there is a consistent data quality checking process that the JRF team undertakes when getting information from the countries, be it through looking at the trend analysis or looking at other supplementary information, for example, information related to vaccine that have been purchased from external sources, like UNICEF has most of the time purchases vaccines, so they can try to triangulate the information that is reported to the JRF against those type of information as well.
Okay, thanks, Tesfaye. And thank you to our audience for all of your very thoughtful and thought-provoking questions. It sounds like the questions and answers hopefully have been useful to everyone in the audience. We're out of time, so unfortunately we can't take any more questions. So let's go back to Grace Chi from Linked, who's going to tell us about some resources available to you.
Okay. Thanks for and thank you to everyone who joined us, our webinar today, for the great questions and the great discussion. I especially want to thank the panelists for taking the time to share their experiences and perspectives with us. I just would like to make a few comments based on some of the last discussions. I think going back for quite some time, there have been some concerns about the data quality on the JRF, and some of the global level checks that have happened have revealed that, there are likely inconsistencies. So I do think, looking at what's been done here around trying to estimate immunization-specific expenditures based on the SHA methodology may be a good alternative that can be another source of consistent data for us. And just to highlight, some of the points that were mentioned around continuing challenges, even using that methodology, around estimating shared expenses, for example, like healthcare workers, and around estimating household costs, to the extent that there's good data coming out of the SHA estimations, they rely on other data sources as well. So with that, I will just say a few words about some resources that are available on the Abt and Linked websites. So both on the Abt and the WHO website is the SHA 2011 immunization guidance. It's currently only in draft form. Also on the Abt website are policy briefs for Benin, Ethiopia, and Mozambique. Those are currently already available. And on the Linked website is the Immunization Financing Resource Guide that was produced also with Gates funding about, I think, sometime last year, as well as you'll find links to the WHO Immunization Advocacy Resource Library, as well as to the Immunization Economics website. I also want to just remind you that a recording of this webinar will be available on the Abt and Linked websites. And just to highlight a few other additional resources that will be available in the coming weeks is the primer for immunization program managers that Tesfaye referred to, as well as a podcast with practical tips on how to produce and use immunization spending data. And then along with the other policy briefs will be a policy brief for Zambia on the Abt website. So with that, I just want to remind you that a recording of this webinar will be available on the Abt and Linked websites pretty soon, and that once you close the webinar window, you'll get a pop-up for a survey requesting your response. We really appreciate it if you could take a minute to complete the survey. Your feedback will be very useful as we design future webinars. And once again, I want to thank everyone for joining, and especially thank the panelists for taking time to participate in this discussion. Have a good day and good evening. Bye.